So this morning I'd like to introduce Dr. Henry Perry. Many of you all in the international health world know he needs no introduction. He is famous here locally in Boone. He actually grew up in North Carolina, both in Boone as well as Greensboro. And he happens to be the great-grandson of Dee Daughtry, who is the co-founder of Watauga Academy, otherwise known as Appalachian State University. Dr. Perry, he received his MD, PhD, and MPH, all from Johns Hopkins, and he then completed a residency in general surgery at Maine Medical Center. He currently serves in the capacity of Senior Associate in International Health at Johns Hopkins Bloomberg School of Public Health. His research addresses the impact of community-based primary health care programs on health improvement, especially on the health of mothers and children. Dr. Perry founded the NGO Cure Americas and later worked in a variety of underserved areas of the world, including Bolivia, Bangladesh, Haiti, and Appalachia. So with that, I will turn it over to Dr. Perry. Thank you so much, Dr. Perry.
Okay, Lance, thank you very much. Welcome to everyone. I see on this list a few folks that I know. Good to see you all, Amy Metzger and Linda Mobula and Mary Lou Fisher. Thank you for joining. Of course, I may know some of these other people too, but they don't jump out at me. So it's great to have you all here, and I guess all of you can speak at any time. Is that right?
Well, most of them, I believe, they have their speakers turned off so that it doesn't.
Oh, good. Yeah, but if they want to say something,
but they can turn on their speaker when they want to speak.
Okay. So if anybody wants to ask a question as we go along through here, please do that, and I look forward to that. I have developed a passion now for community-based primary health care that grows out of my early experience 3 decades ago in Bolivia when I started a community health project there. And over the years, as I worked in that, I began to see the power of working directly at the community level outside of facilities, particularly for improving the health of mothers and children. And I've been working in this area now for full-time for 2 decades. As Lance mentioned, I originally was a general surgeon, and I practiced general surgery in Waynesville, North Carolina for 10 years while I was continuing to support the work of the NGO that I started in Bolivia, originally called Andean Rural Healthcare, and is now, as Lance mentioned, called Cure Americas. But I got so excited about this approach that I decided I needed to do this full time for the rest of my career. So I'm still going strong at it, and I get more enthusiastic about it all the time because it's enormous potential for saving the lives of mothers and children. So my talk is going to focus on community-based primary health care programs for mothers and children in low-resource settings. I want to give an overview of the current status of the health of mothers and children around the world, which I'm sure is old hat to you all. But then I want to talk about a couple, Abhay and Ronnie Bang, and their work in India, which has been pioneering for community-based primary health care. And then talk a little bit about community case management of pneumonia, home-based neonatal care, and then look to the future a little bit on community-based services. So according to the most recent State of the World's Children report that UNICEF released just only a few weeks ago, the current number of children dying around the world every year is now estimated to be 6.9 million. We're making a lot of progress on that, but still most of these deaths are readily preventable or treatable, and therefore they represent an enormous public health challenge, not to mention the moral and ethical implications of such a vast number of human beings dying from diseases and conditions that we know how to manage and to prevent the deaths from these. This map that you see here is from a paper that was published 10 years ago now, so the precise numbers may not be current, but I think the map would look very much the same if we were to reproduce it based on what we currently know. But you see this enormous number of deaths in South Asia, and then of course scattered throughout Africa there are lots of red dots, but particularly in Nigeria and in Ethiopia there are very large numbers of deaths. But it's also striking the very small numbers of deaths that take place in South America and Central America relative to Africa and in particular South Asia. Each one of these deaths, each one of these red dots, I think, represents about 5,000 deaths. The Lancet, only a few months ago, carried out another analysis of the causes of death of children, and this hasn't been changing very much for the last decade or so, but it's becoming increasingly apparent that a major proportion of under 5 mortality is now in the neonatal period. So you see here that represents 41% of under 5 deaths. There are 3 main causes of neonatal deaths: preterm birth complications, birth asphyxia, and then infections or sepsis. In addition to the neonatal deaths, we have other major causes, mainly pneumonia and diarrhea. So you see here about 18% of all under 5 deaths, including neonatal deaths, are from pneumonia, and about 15% are from diarrhea. HIV, AIDS, and malaria are commonly considered to be leading causes of under 5 mortality, but on a global basis, that's really not true. If you go into the next slide I have here, which is for Africa, you see that even within the African context, AIDS is not a important direct cause of death, although it may be contributing to some of the pneumonia and diarrheal deaths. Malaria is a major cause, causing 16% of deaths, but it still falls behind pneumonia as the leading cause of death. And still, of course, in Africa, neonatal deaths are very important, even though they're not 41% of under 5 mortality. They still represent 29% of under 5 mortality. We're making some progress in achieving the Millennium Development Goals in health. MDG 4 is supposed to achieve a decline in under 5 mortality by 2/3 by the year 2015, which of course is just right around the corner. This next slide is from a recent update provided by the United Nations regarding how we're doing in achieving MDG 4 for children. And you can see for sub-Saharan Africa that we're still a long ways away from achieving the goal, which is that yellow line there. We have made progress, but a long ways to go. And of course, if you look at all developing countries down at the bottom of the slide, you'll see we have a long ways to go. But still, the great majority of this challenge is still in Africa, although Asia is certainly an important area, South Asia, but Africa is the real challenge on this. As we look at trends over time on under 5 mortality in this next slide, you can see that even though under 5 mortality overall is declining, the neonatal mortality is declining much less rapidly. So you can see that as time goes by, the proportion of under 5 deaths accounted for by neonatal deaths is increasing. And so much of global health policy and even research now is focused on what we can do now to accelerate the decline in neonatal mortality. And this is why the work of the bangs is so important. It's also interesting to note that among the neonatal deaths, there's a tremendous concentration of those within the first week of life, as you see in that bar graph in the bottom left of this. So during the neonatal period, there's a rapid decline in the numbers of deaths as you go through each day during that neonatal period. At the present time, we're still having a lot of maternal deaths that shouldn't be occurring, although the absolute numbers of these deaths is far less than the numbers of deaths of children, somewhere in the order of 326,000 to 535,000, depending on which report that you're looking at. But even though the actual numbers of these is far less than the numbers of child deaths, they still represent a tremendous tragedy, not only for the woman who dies, but for the family left behind. 99% of these deaths, as well as 99% of under 5 deaths, are taking place in developing countries. The Millennium Development Goal 5 is to reduce maternal mortality by 75% by the year 2015. And according to this report from the United Nations, we still have a long, long ways to go in order to achieve this goal. So it's going to be interesting to see how long it's going to take to achieve the Millennium Development Goals for mothers and children. I think all of us know that for maternal mortality, the leading cause of death is hemorrhage, but important other causes are sepsis, infection of some cause, abortion-related causes, and then eclampsia or preeclampsia. Obstructed labor is important, and then there are a variety of other associated causes as well. So it's becoming readily apparent now that we have a tremendous public health as well as ethical challenge for addressing the health needs of mothers as they approach active labor and of their fetus and newborn during the intrapartum period and within the 48 hours following the birth of a child. So it was during this 48-hour period that we have 150,000 maternal deaths, 1.2 million stillbirths, and 1.5 million early neonatal deaths during this period. So how to design programs that can effectively reduce mortality during this period is a topic of tremendous interest all around the world now, as we all know. I'd like to say a few comments about undernutrition. I think we're all aware that nutrition is important. The Lancet published just a few weeks ago a new series on undernutrition that updates all the current research in this area. And of course, Johns Hopkins has played a leading role in all this research. Dr. Bob Black, who has been the chairman of the Department of International Health here, is the senior author on the lead article in this, and had coordinated this enormous effort to bring all this data into prominence through the Lancet. And this series actually is downloadable off the internet to anyone. You don't have to have a special access to get this. The Lancet, for their most important global health articles, you can download these if you just go to their website and go to their global health series. But according to this, about 26% of all children in lower and middle income countries are suffering from stunting, 165 million children, with high levels in Central Africa and South Asia. 19 million children are severely wasted, and 32 million children are born each year with intrauterine growth restriction, a low birth weight for dates. This is an enormous number. And then we have a very large number of under 5 deaths that are attributable to vitamin A and zinc deficiencies, about 4% of under 5 deaths now according to their estimate. And then of particular importance as well is the number of deaths of children that can be attributed to suboptimal breastfeeding. Current estimate is about 12% of under 5 deaths. And all the time I'm mentioning about how this is really a tremendous public health tragedy, that something that's so simple, that costs nothing, is still a major problem, and public health has not done what it could have done or should have done or needs to do to really develop programs and approaches to expand the coverage of optimal breastfeeding, exclusive breastfeeding during the first 6 months of life particularly. This is a slide that shows that for children who are undernourished, here based on weight for age, as the level of undernourishment increases, that is, as you move from the right side of this chart to the left, as you become more undernourished, the risk of death goes up dramatically if you develop diarrhea, pneumonia, malaria, or measles. And the other interesting thing about this is that most children are moderately nourished rather than severely malnourished. But when you add up the public health burden of moderate malnutrition and its implications for mortality, it's really quite substantial. I remember when I was studying public health 40 years ago now, I remember reading that somebody had done an analysis that indicated that the risk of mortality of a child who developed measles in a developing country was 300 times greater than the risk of mortality for a child who developed measles in the United States. And of course, that difference is really a reflection of the difference in the nutritional status of these children. So when you add up all of this research that came from the Lancet, their conclusion is that at the present time, almost half or 45% of child deaths can be attributable to undernutrition. Of course, they may die as a final cause of diarrhea and pneumonia, but the nutritional factor is tremendously important, but it's not always recognized. 3.1 million children are dying each year as a result of undernutrition, and that undernutrition in pregnancy also is an important contributor to fetal growth and low birth weight, which is a major contributor to neonatal and infant mortality. So, we need to take notice of the fact that really very few countries are on track to achieve the Millennium Development Goal for Children, MDG-4, and in fact, only a few countries in Africa are on track to achieve this goal. The last count I saw, the only countries on track were Eritrea, Liberia, Madagascar, and Malawi. And even fewer countries are on track to achieve Millennium Development Goal 5 for reduction of maternal mortality. Even though these statistics are less than we would like for them to be, we are making progress, but it's just terribly slow. I have seen some statistics that said that at the rate we're going, we won't really achieve these goals for another 100 years unless we do something to accelerate the progress. So we have a big challenge ahead of us to really make the kind of national and demographic impact that we need to, and how we translate this into the work of smaller programs is an important issue as well. Here we're going to move into a new section and talk about one of my global health heroes, Dr. Abhay Bang, and you see him here holding a newborn. Abhay and his wife Ronnie were students here at Hopkins back in the late 70s, and they started their NGO work in India in the early 80s, and so have now been doing this for 30 years, and they're tremendously dedicated people, very bright, They've been living in this very isolated part of central India called Gacharoli now since 1981 when their program started. It's called SEARCH, Society for Education, Action, Research, and Community Health, and they've carried out pioneering research and community-based approaches. Carl Taylor, who started the Department of International Health here back in the 1960s, was their mentor, and I had the great privilege of being at SEARCH with Carl and the Bangs several years ago, and you see a picture here of Carl with them. The program that SEARCH has developed is very simple in a sense, but it's very profound in another sense. It's not a big program. They serve a total of 80,000 people. But they have developed an approach that grew out of their work here at Hopkins and their education and their involvement with Dr. Taylor that is very similar to the kind of work that we started in Bolivia that I was involved with. And you see the principles that they have operated from over this last 3 decades, establishing a relationship of trust, using locally acquired information to identify epidemiological priorities, responding to community priorities, and monitoring health status through what I call routine systematic home visitation. And they have done this in a way that has enabled their findings to be published in the Lancet and has had a pioneering impact in a number of different ways, as you'll see. We're not going to look at this video here, but if you'd like to, after we get off of this, I encourage you to take a look at this, and I've got a few more that I'll tell you about in a minute. This one is 2 minutes long, but it gives Abhai's a very inspiring approach to the importance of working with communities and empowering local communities. But one of the things that they did, to give you an example of how they responded to local community priorities, was they realized that alcoholism was a priority of the local people, and so they developed a program to help deal with alcoholics as a response to community perceived needs that weren't necessarily epidemiological priorities. But in addition to that, they found early on, in response to their determination of the causes of death in their program area, that pneumonia was the leading cause of death, and so they developed an approach for what today we call community case management of pneumonia, and they were one of the very first groups to demonstrate the power of training community health workers to diagnose and treat pneumonia, and this is their article that was published in the Lancet in 1990. And you can see here from this data that they had a dramatic decline in the numbers of pneumonia deaths in their intervention area compared to what they had in their control area. So in their population of 80,000 people, they divided it into 2 parts. Even though the NGO served the entire area, they developed this pneumonia intervention in an intervention area of about half of the overall program area, and then they continued to collect the vital events from the control area. And the overall decline in mortality for the intervention area compared to the control area was about 30% for all children in the first 5 years of life, as you can see in the bottom of Table 5. But there was a dramatic decline in all age groups. The neonatal mortality declined by 30%, infant mortality 27%, and mortality among children 1 to 4 years of age declined by 25%. So I'm sure that probably all of you have heard of these very basic approaches to diagnosing and treating pneumonia, but it involves the counting of the respiratory rate, and these change a little bit from year to year. But if there's rapid breathing present, or if there's what they call chest indrawing present, then those are sufficient for making a diagnosis of pneumonia. without having a stethoscope or a chest x-ray. And so this is a tremendous step forward in terms of making a community diagnosis that illiterate trained village health workers can make. And then the other important part of this is that oral antibiotics are used to treat this pneumonia. And as this whole approach began, and the Bangs were one of the global leaders in developing this, the criteria were very strict for patients with severe or very severe pneumonia being referred on to a facility. But as time has gone by, there's growing evidence that even these more severe cases can be effectively treated at the community level. And part of the problem is that parents in so many settings just won't take a child to a health facility, even if they do meet these more severe criteria. So that's an area of important research. But with the work of the Bangs and other pioneering studies, it was possible to carry out a meta-analysis of a series of studies that have been carried out on community case management of pneumonia. And this was published in the Lancet Infectious Diseases in 2003. And when they did a meta-analysis of these studies, they showed that the overall decline in mortality was on the order of 24%. If you see on this next slide at the bottom on the left, the risk ratio was 0.76. And for pneumonia-specific mortality, the decline was 36%. As you see on the right, the risk ratio was 0.64. So these are very substantial reductions in mortality that can be achieved. And these are all community case management studies in which community health workers are diagnosing and treating pneumonia according to these criteria. So in this next slide, you see a link to a Save the Children video that I show to students all the time, which I like a lot, which gives you a sense of the power of community case management and shows a child who is very critically ill from pneumonia and his follow-up later following community case management. So you might want to review that at some point if you want to. So this next slide simply points out a more recent study in which children who had severe pneumonia were treated at the community level by community health workers, showing that the results are equivalent or even better than what would take place in a health facility. So as a result of all of this research now, it's recommended by WHO and UNICEF that community case management become a standard of care for children with pneumonia. But unfortunately, the distribution of this approach has really lagged behind, and it's a cause of great concern for why it's taken so long to get these interventions scaled up and authorized by country governments. And there are a lot of reasons for this, but I think the most important one is that there's been resistance by medical associations and nursing associations to allow governments to create policies to make this possible. So there's a lot of work and effort going on now about how to overcome this obstacle to make this intervention more widely available in countries where so many children are dying from pneumonia. The Bangs also, in addition to their pioneering work in community case management of pneumonia, they moved from that in the 90s, in the early 90s to in the late 90s and the early 2000s, developed a pioneering approach to community case management of neonatal deaths and what we call home-based neonatal care. And so as they were able to reduce mortality from pneumonia in this very poor rural area of India, they realized that neonatal deaths were the major challenge to be taken on. And so they developed an intervention that could be delivered by their community health workers there. And they reported this in the Journal of Perinatology in 2005, which is one of the pioneering articles, in my view, in global health now. But they were able to demonstrate in this small area again with an intervention in a control area, they were able to show that home-based neonatal care could reduce neonatal mortality by 70%. And they had reduction in the case fatality from infections, substantial, of 63%. They reduced mortality among low birth weight and preterm babies by a major amount. And they also reduced neonatal morbidities as well. And here you see the rapid decline of neonatal mortality in their program area in this report. So what were the principles of home-based neonatal care that they developed in Gacciaroli? Well, the first thing is their program visits every household on a monthly basis, so they're able to identify pregnant women as they become pregnant, and then they have a special protocol of visiting every pregnant woman twice during their prenatal period, and then they work out a scheme whereby the community health worker is present when the mother gives birth, and almost all of these women have a traditional midwife who attends the delivery, but the community health worker takes care of the newborn. And then after the birth, then the community health worker makes frequent visits to the home during the first week, and then progressively fewer visits during the following several weeks of the neonatal period. The community health workers are taught how to manage birth asphyxia. They're actually given a small ambu bag to use, and they promote early and exclusive breastfeeding, among other things that are now standard principles of home-based neonatal care. They weigh the child at birth to identify low birth weight babies, and those babies receive a more frequent home visitation schedule than normal birth weight babies. They taught these community health workers about how to prevent hypothermia, proper cord care, and they have a special, very simple checklist for identifying neonatal sepsis, and they teach them to give injectable antibiotics, actually, if a child has symptoms of neonatal sepsis, which really revolve around poor sucking and lethargy. And then referral is recommended after initial treatment if they develop neonatal sepsis, and then a strong system of supervision and support. So all of this fed into what the Bangs did. And this whole approach, as I'm sure probably everybody knows, has now been replicated in a number of other settings. And there was a meta-analysis of this, 13 studies of this now, published in 2010. And the result of that was that overall, when you pool all these studies together, home-based neonatal care results in a 24% reduction in neonatal mortality. Not all of these other programs train community health workers to give injectable antibiotics. They don't all treat neonatal sepsis, and they don't all give the rather vigorous treatment of birth asphyxia that the Bangs did. But even in those situations as well, there was a substantial decline in neonatal mortality. So as a result of all of that, it's now recommended by WHO and UNICEF that community health workers should make frequent visits to the home where a newborn has arrived to promote these basic principles. They don't recommend on a broad basis now the use of injectable antibiotics, for example, for newborns, but still these basic ideas are widely accepted now and being promoted in countries all around the world. So these are just two of many examples of the power of interventions provided by community health workers in the community that can make a tremendous difference. And I have gotten very excited about community-based primary health care more broadly and what can be achieved by more strongly developing programs that enable these interventions to be delivered. We all know that facilities in these high mortality resource constrained settings are rarely accessible to a large proportion of the population. And we also know that behavior change is so important for the health of mothers and children. And it's becoming every day more apparent that community-level workers can effectively diagnose and treat many life-threatening conditions. So we see here and on the following slides just most of the kinds of interventions that can be provided by community-level workers out in the villages working with local populations. Immunizations, of course, that requires a supply chain and so forth, a lot of technical things related to that. Vitamin A supplementation, zinc supplementation is becoming a more powerful tool. Appropriate breastfeeding, appropriate complementary feeding, hygiene, very simple things, but very strong evidence of their power. I won't read all of these. I'll let you look through these, and I'm sure that you've heard of pretty much all of these. I did type into this slide over to the right, you see chlorhexidine to the umbilical cord. So there's been a lot of research and very powerful randomized controlled trials now using chlorhexidine applied to the umbilical cord, and that can have, in a number of different settings where there are home births taking place, a substantial effect in and of itself alone without any other intervention on reducing neonatal mortality. Community-based rehabilitation of children with severe malnutrition, severe acute malnutrition is getting a lot of attention. I'm sure you all are involved in that. I won't go through all of these as I mentioned. But what's less known now is the power of community-based interventions for improving maternal health. Perhaps the most important of these is community-based approaches for family planning. This has been around for a long, long time, but as funding for family planning declined over the years, the whole power of this has become lost. But family planning is the most cost-effective way of reducing maternal mortality, because if a mother didn't want to become pregnant to start with, then if she doesn't get pregnant, that she can't die a maternal death. There are now growing efforts to look for community-based approaches to detect preeclampsia early on, and also to treat eclampsia even in the community level, but that's still a ways off yet. But JPIGO here at Hopkins is doing a lot of work now to develop very simple devices that community health workers can use to develop ways of measuring elevated blood pressure among pregnant women. Of course, that has relevance beyond pregnant women as well. And then cheaper ways to develop dipsticks for determining the presence of proteinuria in pregnant women. So in addition to that, there is all these very basic, simple approaches to reducing maternal mortality in the community, from cleanliness in the delivery, immediate breastfeeding to reduce the risk of postpartum hemorrhage, and then misoprostol, a very dramatic intervention to reduce postpartum hemorrhage by providing to a woman to take immediately after birth, if she's giving birth in an isolated place, 2 pills that will cause a uterine constriction and reduce the risk of postpartum hemorrhage. And JPIGO, again, is involved in this research, and their work in Nepal and Afghanistan has shown dramatic results in terms of reduction of postpartum hemorrhage and even reduction of maternal mortality. And so we're going to be seeing more research on this and more efforts to make this very simple intervention widely available in areas where maternal mortality is very high. There have been several studies now that pull together all of the findings of these kinds of interventions and these home-based neonatal care interventions have also been found to reduce maternal mortality, and this is one study that was published back in 2008 that looks at the first 4 of these approaches that essentially involve empowerment of women and teaching them about signs of risk factors for complications from pregnancy, and also at the same time bring in some of the important concepts on reducing neonatal mortality. But you see here that the impact of these 4 studies on maternal mortality is substantial. And so there's growing efforts on how to empower women to take actions that can reduce maternal mortality without doing anything at all at the facility level. And in addition to that, there has been a study that just came out a few weeks ago in The Lancet that looks at one particular kind of community engagement that I haven't talked about, but they refer to it as participatory learning in action, in which a promoter goes to a village and meets with a group of women to teach them about warning signs during pregnancy and proper care of newborns. And these are randomized controlled trials, and there are 7 of these now that have been carried out, and there's a meta-analysis of this approach that shows a dramatic reduction, 37%, in maternal mortality using these community-based approaches. So, given the fact that we have this vast number of mothers and children dying from readily preventable treatable conditions from all over the world, how can we address this given the fact that we know that these interventions are out there and they work, and how we can bring the moral dimension, not to mention the spiritual dimension, into this is terribly important. And so all of us in our own smaller ways, and Samaritan's Purse is certainly making an important contribution to this area. We're all doing what we can, but I think it's a moral issue that needs to become on a much broader basis than it is now. I say now in the world of the 21st century, no mother or child should be allowed to die from a readily preventable or treatable condition that communities can manage. So building these stronger community-based approaches is going to become increasingly a major task for global health, and it's going to be exciting to see this progress move forward. You may have heard of this whole movement for ending preventable child deaths by the year 2035. I had the privilege of being a part of this conference that took place at George Washington University a year ago, in which the U.S. government and other leading governments, along with UNICEF and WHO, launched this effort. And the whole idea is that over the next 20 years, we want to accelerate the decline in under 5 mortality and also maternal mortality, so that by the time we reach this moment in time, the levels of mortality in poor countries would be similar to what they are in developed countries. And it's going to really require a doubling in the rate of decline of mortality. And the only way to do that is by really strengthening these community-based approaches. And so it's going to be an exciting chance for all of us to be a participant in these kinds of activities. And of course we need the research to document the impact of these, but we also need programs to implement these findings and to do them at scale. And how NGOs like Samaritan's Purse can contribute to this is an important question for all of us who work within the NGO world. But I think we're moving into an exciting time. Of course, the tragedy of these needless deaths is still with us, but I think we're learning more all the time about how to address these and reduce these deaths. So I know that I've gone over a little bit more than I wanted to give you a chance to ask some questions. But I have here on this next slide a video about JomKed, which probably all of you have heard about. But if you haven't, this is a very wonderful video from National Geographic about their community health worker program. And then there's another tremendous video about the importance of expanding community health workers so that everybody has access to a health worker. So you might enjoy those if you have a chance to look at them. So let me stop there. I think it's about 12:50, so somebody may have a question, and I didn't hear any in the process, so I'm sorry if I inhibited any of you from asking a question in the process.
Well, Dr. Perry, thank you so much. That was a wonderful presentation. Does anyone have any questions for Dr. Perry?
Dr. Perry, this is Tom Wood. You and I could spend hours talking. You and I have been on that trip. I have not been on it nearly as long as you have. But I just sat here and did a rough calculation. In the time that you were talking, 800 children died and 50 women, died in childbirth or perinatally. And I agree with you. That is a moral imperative that we have the ability to stop, and we need to be busy about doing it. And so, we have a program here we call Village Samaritan, which we are trying to get up and running. We do have it running in 8 villages in Honduras, and it is exactly what you were talking about. Is community-based. We even go into the village and have them, we set up a health committee and then have that health committee select the people we will train. I have found, you mentioned in the beginning of your talk that there was government resistance in a lot of countries towards, community-based programs. And what I've found over the few years that I've been researching it is more and more countries are coming around to the realization that this is going to be the only approach that's really going to work in reaching their remote areas.
Right.
I applaud your work, and I look forward to maybe you and I sitting down and having a long conversation.
Sure. Well, the whole rationale of resistance from professional organizations is interesting because there are two main arguments that are given. One is that it's going to take away from the business of people who make money from treating these people, but there's so much business out there, it's hard to imagine why this is going to have an impact on physicians' incomes or even nurses' incomes. The other one is that, giving these people the access to antibiotics is going to accelerate the production of antimicrobial resistance. And the implication is that doctors know how to treat these conditions correctly, and there's really no evidence that doctors do any better at this than community level workers do. And so the whole notion that this is going to make a worsening of the problem of antibiotic resistance is not really a very powerful argument, I don't think, but I've heard that raised from time to time as well. So I think, it's hard to, even though there's social factors that lead to resistance, getting obstetricians to wash their hands back, in the late 1800s was an enormous thing too, but it's hard to debate science and real hard facts, and I think the science for all this is so strong, it's going to continue to gain steam, I think, like you say, Tom. So hopefully the resistance is going to start to melt. I know in the early days when oral rehydration therapy came along, there were a lot of professors of pediatrics in countries who refused to believe that oral rehydration therapy actually worked, and there was a lot of research that was done within specific countries to prove that it worked within that country, so they wouldn't accept it unless they did the research on their own. And a lot of that's happening too with these interventions as well. It's taking place within countries to provide a more powerful source of evidence to people who might be skeptical. So this is coming along too.
Yeah, I see you've got another question up there, and I don't want to dominate your time because you and I can talk offline. But just wanted to talk into a little bit the notion that, overuse of an antibiotic will lead to resistance. I'm a Hopkins-trained epidemiologist also, and that's simply not the case. What happens, it's misuse of antibiotics, not overuse, that leads to resistance. And it's, starting one and then 2 days later stopping it, so that if we build into the community case management program, we take away the possibility that it will be, we don't give them 10 days supply, we give them a day's supply at a time, and then we make sure that they take it before we go to the next. Instead of giving somebody a 10-day supply and you're in a resource-poor country, they use 2 days' worth and then they sell the rest of it because they feel better. So that's the kind of thing that leads to resistance, not the fact that you're taking an antibiotic for the full course of the full recommended time.
Yeah. Well, yeah, there are lots of important issues here. But let me go to the other question, which was about calcium supplementation.
Mm-hmm.
And basically, what I understand from one of my gurus is Dr. Harshad Sanghvi, who's the vice president at JPIGO and a world-renowned obstetrician and gynecologist. But there is, like Amy said, the research supporting calcium supplementation was pretty dismal. And what he tells me is that the reason is that this calcium tastes so terrible that women won't take it. There are now studies underway in which there's something called calcium sprinkles that they can actually sprinkle on top of food so it doesn't have this terrible taste. And so those studies haven't been published yet, but he's very hopeful that that's going to make an impact on preventing the occurrence of preeclampsia. So it's just another example of a community-based intervention that's coming along that has potential for being applicable on a broader scale. I hope that answers your question, Amy.
Thank you. Any other questions? We're just about out of time. I did just want to say, I just wanted to make a general advertisement about Samaritans Purse International Health Forum. We are really encouraging multiple Christian NGOs and humanitarian NGOs to join our International Health Forum, really to promote this kind of dialogue and really learn from each organization what the other is doing and learn how we can integrate and work together to achieve some of these efforts that Dr. Perry has described today. One of the things we want to do as we move forward is develop this as a platform where you can even make brief advertisements, if you will, about what your organization is doing. For example, I'll just give one. This November, we're proceeding with our third collaboration with Juba Teaching Hospital in South Sudan for cleft lip and palate repair. That program has been largely successful thanks to Beth Thompson and Karen Daniels for their outstanding work. But one of the things we can do is use this forum to just advertise interventions and projects that we're doing and look forward to other organizations joining us. I'll close with thanking Dr. Perry. Thank you so much.
There's one other question here, Lance, from Julie.
I'm sorry. Okay, Julie.
Hi, sorry about that. Dr. Perry, thank you so much for your presentation. There was a lot of excellent information. I had a question. One comment on the calcium thing. I know from the last Lancet series, based on the meta-analysis, they do recommend now calcium supplementation to prevent preeclampsia. But yeah, I know for one thing you mentioned was about training women almost kind of like traditional birth attendants to be able to provide the neonatal care, right? Do you recommend moving in that direction or moving women towards these like birthing houses to be closer to actual facilities? And I know there's been a push towards that kind of programming as well. I mean, it's kind of one or the other oftentimes. So do you have a recommendation on whether you think one?
Well, yeah, I didn't mention it, but it is on my slide. Birthing homes I think are tremendous. I think they need to be encouraged, but it also isn't by itself sufficient because home-based neonatal care needs to take place even after the mother's gone back home as well. So I think that we need all of these things. They're not mutually exclusive.
Lance, can I ask a real quick question? Mary Lou here.
Yes, ma'am.
Okay, the banks that work with the community health workers, are these community health workers educated, or are they illiterate? Do you know?
Yeah, they're almost all of them are illiterate, but they are paid. So there are lots of examples where there are similar kinds of people who aren't paid, but they do pay theirs. But it's a very small amount of money.